go ahead. Okay, we can start the recording. So Silvia today will present us a lesson on coronary aneurysm. So please, Silvia, the podium is yours.
Thank you very much. It's my pleasure to share with you my experience about the coronary artery aneurysm. I have been dealing with the coronary aneurysm for about 10 years, and this is a well-known topic for me. And first of all, I would like to present you some definition and some basic knowledge about the aneurysm, the definition. So the coronary artery aneurysm is defined as a focal or diffuse dilatation of the artery with the diameter of more than or equal to 1.5 times the adjacent normal coronary segment. And we can divide it into the fusiform aneurysm when the longitudinal length of the aneurysm is more than diameter of the aneurysm, and saccular aneurysm when the diameter is larger than the length of the aneurysm, like this picture. And then we can say about the ectasia of the coronary artery when the dilatation is more than one third of the artery, like at this the last picture. And
okay, so the reference for the aneurysm, the diagnosis, is the lumen and not the vessel size. So we can speak about aneurysm if, according to the lumen reference vessel diameter, we have an ectasia more than 1.5.
Yes, that's right.
Yeah.
So we can generally the definition is based on the angiography. So we are talking about the lumen. There is examples of each type of aneurysm and ectasia. On the first picture, we can see fusiform aneurysm. There is a saccular aneurysm on the bifurcation of diagonal branch and LAD. And there is an ectasia of circumflex artery where whole artery is dilated. What problem is with coronary aneurysm and ectasia? It's a quite rare vascular pathology. It's diagnosed in up to 5% of patients undergoing coronary angiography. The prevalence of coronary aneurysm is a little bit higher these days because of the higher frequency of CT angio-CT of coronary arteries, so we can diagnose coronary dilatation a little more frequent. The most common etiology is atherosclerosis in our population. In Asia population, Kawasaki disease is the most common reason of coronary dilatation. And we can also remember about the vasculitis, infectious septic emboli, and connective tissue disease. Also, it can be a reason of coronary dilatation, but it's quite a rare reason. Coronary aneurysms are often diagnosed incidentally, but when the patients are asymptomatic, generally stable angina symptoms are the most common symptoms. But we of course have remember about the unstable angina, acute myocardial infarction. The most common reason is in aneurysm thrombosis and distal embolization of the artery. Arrhythmias due to the ischemia, heart ischemia, and sudden cardiac death. It's also potential complication of aneurysm. And let's look at the MACE occurrence. It's up to 10% of all patients with diagnosed coronary aneurysm, so it's a higher frequency than the other patients. The risk of myocardial infarction and myocardial recurrence is also higher in this group of patients. So it's generally high risk population than normal population without coronary aneurysm. The problem is, of course, with the pathophysiology of coronary aneurysm. As I said, the most common reason is atherosclerosis, but we generally don't know why only in some patients with atherosclerosis the aneurysm are developing. Generally, probably there are some other factors that increase the risk of aneurysm development. The problem is also with management of this patient because generally we don't know how to treat them. The one of the way of percutaneous intervention is covered stent implantation. However, we have to remember about the increased risk of thrombosis inside the stent graft. In some group of patients, when the aneurysm is saccular and very large with increased risk, very high risk of rupture, we can think about the coil embolization, and sometimes in subgroup of patient, surgical intervention is also a good treatment method. But of course, it's very individual approach, and there is very difficult to compare these three interventional treatment methods. Of course, the most of patients are treated pharmacologically and the question is which drugs are the best for this patient. In each patient, we have to think about the anticoagulation to decrease the risk of aneurysm, thrombosis, and distal embolization, or dual antiplatelet therapy or single antiplatelet therapy. So there is many questions. We don't have any answers about for these doubts. So there is the method of choice for diagnosis is, as I said, it's coronary angiography, but we are doing in our patient also OCT. It's quite difficult to capture the whole cross-sectional view of whole aneurysm. It depends on the size, but now we are doing OCT in our patient and try to assess the remodeling of the artery.
So which are the advantages, in your opinion, of using this modality of imaging on top of angiography?
So this is generally we are doing OCT to get knowledge about the remodeling of the artery and potential reason of aneurysm development. So, and of course, in aneurysm thrombosis and thrombus. So this can change our decision about the anticoagulation in our patients. So I think this is most important point.
And another advantage, there are two other advantages, in my opinion. One is that you can actually see, if you don't have a CT scan done previously, the thickness of the wall in the aneurysm. which can be correlated to a potential risk of rupture. So we can have some additional information which go on top of what the luminalography is able to provide us. And then another thing is that sometimes some aneurysms are associated to stenosis. And these stenosis, in my experience, are not very easy to be treated. They are usually very fibrotic or calcific, and you need to tailor a therapy according to the imaging. So these are, in my opinion, two additional important clues that imaging can provide.
Yes, that's right.
A small point to make. Can you hear me?
Yes.
2 points. One is that I agree with Bernardo that imaging offers a lot of extra information about the size of the vessel, etc. But the choice of imaging, if it's a focal aneurysm, then OCT is fine. But if it's an ectatic vessel, the contrast, the clearance of the blood is not easy with the OCT. Yeah. And in those patients, I tend to use more Boston IVUS, which gives a better imaging quality. Now, the other point is you mentioned, the other important point you mentioned about the cause. I think one of the thing is the Kawasaki. I don't know whether you mentioned that. I may have missed it, because sometimes if you have a Kawasaki disease previously, they are prone for ectasia of coronary arteries.
Yeah, of course. Okay, perfect. Silvia.
This is another example of saccular aneurysm in proximal segment of RCA and mid segment of LAD. Give me 1 minute, please.
Yeah, I have a problem with the baby, I guess. Any questions so far? Amanda, Jacinth, Rima, Sarah?
No, it's clear.
Okay.
I'm sorry, I'm come back.
Yeah.
Okay, so,
all right.
I'm sorry. Okay. Okay, this is another example of fusiform aneurysm in the proximal and mid segment of LAD. We can observe the slow flow inside the aneurysm of contrast. So there is a turbulent flow. This is, of course, one of the risk factors of inside thrombosis. And this is ectasia of whole left coronary artery. And there is also slow flow. And we can see that the risk of thrombosis in this type of arteries is also increased. Now I would like to present you a short case, and this is a 35-year-old male presented with STEMI of anterior wall without cardiovascular risk factors. So let's look at the coronary angiography. This is right coronary artery without the significant lesion, a little slow flow. And this is the left coronary artery with dilatation of left main on bifurcation and proximal segment of LAD with occlusion of large diagonal branch. It's better visualized here and on AP projection. And unfortunately, I don't have IVUS because after the thrombus aspiration, the IVUS was performed and there was any atherosclerotic plaque inside the artery. So probably the reason of the myocardial infarction was in aneurysm, thrombosis, and distal embolization. This is the after the wiring and thrombus aspiration, and we can observe restored flow through the quite large artery. There is a case too. A 27-year-old woman was admitted.
So in that patient, you just did a wiring.
Yes,
that's
wiring and thrombus aspiration.
And thrombus aspiration, yeah.
Yes,
okay.
Without more intervention. And
as a treatment, treatment, what did you do to this patient?
The treatment was antithrombotic drugs. Apixaban was given with ticagrelor with aspirin. That's all. And the patient was admitted one more time 1 week ago, and the coronary artery are clear. And I did microcirculation assessment. I will show you in the next slides in this patient. Okay. And EMR was very high in this patient, and acetylcholine test was also positive. But generally, the patient was treated without any intervention, only pharmacologically.
Okay. And excuse me, the duration of treatment, triple therapy for how long?
It was okay. We used we decided after the short treatment with ticagrelor, we decided to change the treatment into aspirin, clopidogrel, and rivaroxaban in a small dose, 2.5 milligrams.
But why rivaroxaban? Because rivaroxaban at that dosage is not an anticoagulant.
Yes, that's right.
It has been studied only in secondary prevention for some high-risk coronary artery disease patients, but not for not as an anticoagulant.
Yeah.
So, do you have a protocol, a specific protocol for using rivaroxaban at that dosage?
Unfortunately, we don't have any experience, and we don't have any data how to treat this patient. So it was a lot of discussion about the way of treatment for him. So we decide to because the rivaroxaban in this dose it's antiplatelet rather.
So my question is, you did IVUS also, if you don't have the images. So IVUS was able to visualize the thrombus or not?
Yes.
Okay, so you have a coronary thrombus. So why didn't you go with a full dose of anticoagulant plus 1 antiplatelet?
Yeah, it's quite difficult. There is no data to give the patient full anticoagulant dose in aneurysm group. Of course,
there is no data for anything, but you know, pathophysiology in this case.
Yeah, it was one of the possible options. Unfortunately, it was not my patient on the ward.
Okay.
So unfortunately, I don't have so much influence on the decision. No,
it was just curiosity, just to discuss. Of course, it's not a critic.
There is one point. There is a document, like a consensus document on the ESC, published several years ago, where they say if it's a first presentation, you can give a long-term DAPT. But if the patient has further episodes of thrombus despite DAPT, then they recommend anticoagulation, not in the first episode. So especially with younger patients, I give them long-term DAPT. But if the aneurysm is very big and thrombus is big, I tend to use one of the anticoagulation upfront, like a DOAC with antiplatelet, as Bernardo mentioned. But we have to decide case-by-case basis. But there's a consensus document in the ESC that the first should be the DAPT, and if there's thrombus on DAPT, then you have to add anticoagulation.
No, but the problem here is that there is no atherosclerosis. So IVUS did show that there is no atherosclerotic plaque that led to thrombus, because in this case, you should go for the APT. Here you have an ectasia, and probably for the Virchow's law, you have a reduced flow. So you have a reduced flow, which leads to thrombosis. So this thrombus is not a thrombus related to an atherosclerotic plaque rupture. And in this case, I would have given an anticoagulant plus one single antiplatelet therapy. Because the IVUS here was very important to let us understand which was the cause for this event.
Yes, I agree. I agree with you. What I could do, I did the control coronary angiography to look at the artery and the thrombus, and there is no sign of thrombus in control coronarography after a few months. But of course, I agree. This is I think, good solution to give this type of patient anticoagulant treatment also.
All right.
Okay, so there I would like to present a 27-year-old woman. She was admitted to our hospital for a recanalization attempt of mid-segment of a lady because 3 months ago she had STEMI of anterior wall with mid-segment occlusion, and there was an unsuccessful pass with the guide wire through the lesion and restore flow. So and now we thought that we have to deal with the CTO of the lady. She has any cardiovascular risk factors. This is a primary PCI, and there you can observe that there is a mid-segment mid-LAD occlusion. There was many attempts to go with the wire through the lesion, but it was unsuccessful. So unfortunately, the flow didn't restore. And this is our coronary angiography 3 months later. And now we can see that we have a flow through the artery, and distally to the segment of the occlusion, we can observe the coronary aneurysm, and it was probably the reason why the wire couldn't pass the lesion, because
the wire did stuck there, probably.
Right, that's right. And probably it was the reason of the same as before. It was probably the reason of coronary occlusion and myocardial infarction. I passed the wire very easily because I saw the distal segment of the artery. I did also an IVUS. There was some atherosclerosis, but it was rather a fibrotic plaque without significant lesion. So I implanted a stent, and it was the final result. I would like to say a few words about my personal experience. So I created a Polish registry of patients with coronary artery aneurysm and ectasia. It's the acronym of this registry is CART-PO. Currently, we have about 800 patients, but our target is more than 2,000. So we have 65 patients with angio-CT. So now I collaborate with Professor Sirais and Professor Onuma, and we are doing very advanced analysis of this patient, and 25 patients with OCT. And these are my research projects. So I focused in the past on a little bit on pathogenesis of aneurysm development. So it was identification of microRNA specific for aneurysm dilatation. Also some molecular analysis. I will show you the results. I think it's quite interesting. And what I think it's the most interesting for me, it's assessment of coronary microcirculation and vascular endothelial dysfunction in patients with coronary aneurysm. I got a grant from Women as One organization. It was a Escalator Research Award 1 year ago. So now I have, okay, this is I sent an abstract to PCR, and it was accepted about the assessment of vascular dysfunction in patients with coronary artery aneurysm. Now we have a 45 patients generally, 15 patients with coronary aneurysm, and 30 patients with INOCA. It's a control group, and we did for all patients, we did microvascular assessment, provocation test with acetylcholine, and we collected blood for determination of endothelial function using special methods. And these are results. So of course the group is very small, but now you can see there is some difference in the frequency of microvascular angina and microvascular, generally microvascular disease, both microvascular spasm and disease. So there is no significant statistical significance, but there is a trend to higher frequency in coronary aneurysm group. Microvascular spasm, the rate is similar, but as you can see, the value of the EMR is significantly higher in the group in patient with coronary aneurysm. I think it's quite interesting, especially that it's very small group. So I am looking for the end of the study, and we will see. CFR is the same. Vasospastic angina, it's also comparable between groups. And I have a question for you, and what do you think? What is this? This is an image also accepted for Europe.
What is this?
Yeah.
Okay. But you found it. It's your image, or
it's my not my procedure, but my colleague did this procedure from my center.
Okay.
So there is an artery. No, it's a still picture. She wants to make us assessment. So I think there's a RCA for me, and there is a wire in the RCA, and I don't know, is it a guide extension or something which is gone into a branch, or maybe the whole thing is an RCA. I don't know.
Okay. Do you have any other idea? Okay, so so I will show you the another picture. So on the first one, this is the RCA.
So this is the whole thing RCA.
Yeah, there is a lot of, it's occluded with huge thrombus. So this is the patient with ST segment elevation myocardial infarction inferior wall, and there you
this was a young patient.
No, it's not young patient. It's 80-year-old woman.
Okay.
Huge right coronary artery with massive thrombosis of the artery, and unfortunately, there was a lot of thrombus aspiration, but the flow didn't restore. And at the end of the procedure, there was a perforation with the catheter. With massive perforation of the proximal segment. So I wanted to show you this picture because I wanted to show that this group of patients is very prone for complication, and the risk of complication it's much higher than the other patients. So the wall.
Yeah, I have to say that.
Rupture.
I don't know, was the patient stable when it came just with the STEMI, or was in cardiogenic shock?
During the first minutes, it was quite stable, but during the procedure, before the perforation, there was a cardiac arrest, and during
No, I mean before coming to the cath lab, patient was stable or not?
Yeah, it was quite stable, but during the procedure, she deteriorated, and cardiogenic shock developed.
Because one point could be the indication to try to reopen this artery, because probability of success is very low. So just a wire attempt to see if you can restore some flow makes sense, in my opinion, but I would be very conservative in these patients because this artery seems really, really fragile. So
yes.
Complication is there. So if the patient is on cardiogenic shock or continuous cardiac arrest, you do whatever. You try to open it with any tool. Otherwise, an inferior MI in an 80-year-old lady can be also managed conservatively. This is my point. Not knowing, not having any additional information of the patient, but this is a very high risk PCI.
Yes, that's right. I agree. And very shortly, I would like to show you the results of whole exome sequencing in patients with coronary aneurysm. We randomly selected 6 patients from our database and analyzed them with whole exome sequencing, and we focus on metalloproteinases. And there is some, we developed that there is some polymorphism in exon 6 of MP9 in 4 of 6 patients. So it's about 60% of our patient had the same polymorphism. So it's very interesting. This polymorphism was responsible for increased activation of thymogen and increased extracellular matrix degradation. So our analysis revealed in single patient the other polymorphism, but I think this one was the most interesting. It was published 1 week ago in Hellenic Journal of Cardiology. Okay, and very shortly, we are doing this type of analysis of our patient with the collaboration of CORIP in Galway, Professor Sears. So they can, not I, but they can do this type of analysis with the tissue, with the characterization in dilated segments. So I think it will be very, very interesting analysis. There you can see CT scan of this patient, and this is the example of analysis with very detailed plaque characterization in dilated segments. Okay, so okay, I think it's it's the same. Okay, I think it's
good. Nice presentation. Very nice. We learned a lot, Silvia. Thanks.
Very nice. Thanks.
We could also perceive your passion for coronary aneurysm, and it was very interesting. And it's also interesting to see the scientific program that you are developing around this. So I'm asking you to keep us updated on the research projects that you have done so far, and of course you will have all of the support of DCB Academy and also for Fondazione RIC for future research on this topic.
Thank you very much. I think this database, which we are developing now, I think it's will be a very good source of data, and there will be a lot of very interesting analysis performed. So I hope we can collaborate together and do something interesting.
Yeah, with pleasure.
Congratulations.
Questions, Wojciech,
No.
Rima, anybody? Everything was very clear.
A small question, Sylvia. Because we are obviously doing a DCB Academy, what do you think the role of DCB in such cases? Because I think DCB probably is ideal because you have a big size mismatch sometimes, ectasia, thrombus. The stent result may not be appropriate or may not even be even a choice. So do you think a DCB sometimes can be helpful in these cases?
Yes, of course, we can create a common database from different countries of this such of cases, because it's not so common. It's very rare, I think. So it will be very interesting to create the group of patients with such cases and analyze it and publish. So of course I am open for collaboration. We are common groups.
I participated to, let me see, to a study a few years ago. Are you aware of the CAR registry?
Yes, of course. This is the biggest registry of patients with coronary aneurysm, but we will be bigger.
Yeah. Now, because I was part of it, let me see how many patients we.
There was some Polish doctors also collaborating in this registry. Yeah. The most data came from this registry now about this patient.
There were 1,500 patients. 1,565.
Yeah.
Yeah, but as Sandeep was saying, of course, I always try to avoid placing stents there. Sometimes you are forced, but if you can avoid that, that would be great, because you have for sure some malapposition. So if you do a follow-up angiography, in some cases you can see that the aneurysm is going to be excluded by the stent, so you can see a sort of pristine vessel after months or years, but there is still a theoretical risk of having this tissue that will be created between the stent and the aneurysm wall to protrude into the lumen and create some thrombosis. So there is this theoretical risk. So a DCB is a more conservative way of managing this type of stenosis associated to the aneurysm.
Yes.
Another thing is the technical aspects of the DCB. So I have a case, maybe I'll show you some time, where I had to use two kissing DCBs in the same vessel because the vessel was 5 millimeter. And as you know, the largest DCB is 4 millimeter. So I used two DCBs next to each other on two wires, and then did an injection just to make sure the contrast doesn't trickle through. So that's one of the technical tips. Yeah.
And the other thing is that I definitely would prefer to use sirolimus in this case, because if you already have a thinner vessel wall with a very small media, paclitaxel there could be, in my opinion, potentially harmful. So I will go for sirolimus for sure.
Point. I totally agree. I think you don't want ectasia of already thin wall. You don't want aneurysm and rupture. Yeah, sirolimus is always.
Dr. Sylvia.
Yes.
And first of all, thank you very much for the very interesting and comprehensive presentation. I have a question. In case of aneurysm at very high risk of rupture, would you manage them via PCI or a surgical resection?
I think it depends on the type of aneurysm, because in such artery, like I showed at the end of the presentation with the perforation with a catheter, it will be very, very difficult and I think impossible to treat with percutaneous coronary intervention because there is any stent graft as with this diameter and there is no landing zone because in some aneurysm, for example, saccular aneurysm or fusiform aneurysm, but quite short when we have a landing zone for stent graft implantation. There is a possible to close the artery and close the leakage at the level of aneurysm, but in ectatic coronary arteries like this, it's I think the only one possible to treat it's a surgical operation.
Thank you. Yeah.
There is a question by Jacinth.
Yes, hello. Thank you, first of all, for the presentation. So I wanted to ask you about away a bit from the coronary arteries. How would you manage aortic regurgitation due to aneurysm coming from the ascending aorta? Would you treat it or would you manage it the same way you would treat any aortic regurgitation?
You mean the dilatation of aortic root?
Yes, yes.
I think in this case, there is only surgical treatment. It's an option for the patient. Not
Yeah, if you have a big ectasia, probably you would have problems in putting a TAVR in it. So that could be a problem. But sometimes TAVR are an option, mostly in the patients that already had cardiac surgery or that are sick, old, all of that. But usually for aortic regurgitation, the first intention is to send the patient to the surgeon.
Okay, okay.
We can have a lesson on this, Sarah. Take note of that. Yeah.
Yes, sure.
Just I have one question, please.
Yes, please, Rima.
When you have a coronary aneurysm like that, would you go for CT angio for whole aorta to see if there is another aneurysm or associated?
Yeah, it's a good point because some group of patients generally with the genetic reason of aneurysm, etiology of aneurysm, the risk of aortic aneurysm is also higher. So we are doing ultrasonography, first of all, of aorta, and also we are doing ultrasonography of carotid arteries because there is also increased risk of aneurysm in this compartment. So yeah.
But from the clinical point of view, how is the increased risk of having an aortic aneurysm in a patient that has a coronary aneurysm?
If I could remember, we are collecting the data from this from our big registry, but if I could remember from our database, there is about 20-30% of patients with coronary aneurysm had simultaneously aortic aneurysm.
Yeah, and these patients are also at high risk of having any other vessel aneurysm. So some of them can have a visceral vessel aneurysm also, which can lead to also ischemic complications or potentially rupture there. There is some problems with the media, probably. Something that, probably your studies will inform us more about in the next future.
I hope.